Our speakers for this panel is Dr. Ina Park, who is an associate professor at the University of California, San Francisco School of Medicine, medical director at the California Prevention Training Center, and a medical consultant to the Division of STD Prevention at the Centers for Disease Control and Prevention. Dr. Park.
So thank you very much, Dr. Boyer. And this is a little bit of a different type of talk than I'm used to giving. I'm usually told to talk about one specific topic, but in this case, I met with Academy staff and they said, reflect on what you've learned during your time and tell us, what you recommend. And so I think my husband and my kids will be the first to tell you that I love telling people what I think they should do. But this was a little bit daunting because there's so many things on my wish list, so I just spent a lot of time reflecting and meditating on it, and I came up with some priority areas that I'd like to address today. So I am funded by the Centers for Disease Control and Prevention, and my current employer is the University of California, San Francisco. So what are we going to talk about today? I apologize if this text is a little bit small, but I will read it for you. I want to talk a little bit about addressing STI-related stigma, and then engaging the public in education and prevention around STIs. And then something that sounds simple but isn't, counting gender and sexual minority populations to be able to assess quality metrics. And then I wanted to give some concrete examples from my work, which I'm currently preparing for publication, around partnering with private sector organizations to increase screening. And then wanted to talk a little bit about expanding patient access via brick-and-mortar STI clinics, as well as expanding online testing platforms. And also just do a little storytelling and giving concrete examples of what I experience as a clinician and the barriers that patients face in obtaining STI services, screening services. And then finally, if time allows, I'd like to talk about removing barriers to expedited partner therapy, which I think would be very effective, hopefully, in reducing reinfections. So can I just say that STI-related stigma is an enormous issue that certainly plays into the prevention of these infections. And it's probably been around as long as the infections themselves have been around. I'm starting with the term venereal disease, which is from the word venery and sort of implying sort of immoral sexual behavior. But in the past 100 years at least, I just wanted to give two concrete examples from the mainstream media, not to pick on Time magazine, but in 1936, the Surgeon General's anti-syphilis campaign actually makes no mention of syphilis. It just says his target is behind a taboo, and then has a full cover shot of his face. So it doesn't actually make a mention of the infection. Then we go to 1984, where herpes is on the front cover, but it's called Today's Scarlet Letter. So you can see how pervasive the sort of conversation nationally is around STIs. And so I wanted to say, most people don't want to talk about them. Most people don't want to be associated with them. And so I wanted to give one concrete example of work that I've done, which won't be published, of course, in this arena, and some thoughts that I've had about this. So I wanted to share some work we did using existing social media platforms to highlight folks that actually were proud to be associated with STIs. So that's me in the middle wearing a t-shirt that says, "Ask me about my STD." It's our division t-shirt at the Centers for Disease Control. I help manage the STD Journal's Twitter account. And I was on Twitter procrastinating one day, and folks were talking about how the field of STI doesn't have many advocates, unlike HIV, that no one wants to be associated with gonorrhea. And folks in the UK were saying, well, I would be associated with this STI. And then folks from Australia and the US were saying, I'm proud to be associated with STIs. So what someone suggested was, why don't we do something at the next international meeting to show how proud we are to be associated with STIs? So I decided to take this on. And at that same time, Amanda Dennison from the National Coalition of STD Directors had posted something which got quite a bit of traction on social media about her own journey with herpes, being diagnosed with HSV2, from shame to empowerment. And then I got my publisher involved at Wolters Kluwer and the CEO of Giant Microbes, who makes these large stuffed STI dolls that you're going to see up in the corner, who agreed to actually come to the meeting and donate a lot of product for the participants. So what we did is we actually set up a photo booth, and we asked people to take a picture with their favorite STI, to share it on Twitter with the hashtag Face of an STI and Stop Stigma. And the first 100 people to do so got a free product from Giant Microbes. And we instilled the conference organizers. You'll recognize Dr. Gatos, who's one of the conference organizers, who was our first face of syphilis and gonorrhea, and then Caroline Cameron and Nicola Lowe, who became the face of syphilis and chlamydia. And the conference theme that year was also Stop Stigma, so it dovetailed really nicely. So we set up this photo booth, and people went insane because people cannot resist free anything. So we were mobbed. We gave away all of the product in the first day, but we had a raffle for these very large items. And so we had people coming in continuously throughout the conference from all over the world. And I just want to show you, we had native elders, folks from Africa, women in hijabs, posing with STDs. It was just like really beautiful. So this is just some examples. We had hundreds of people come. And by the end, in terms of our analytics, in 3.5 days, we had over 376,000 Twitter impressions, meaning the number of times that this hashtag appeared on Twitter, and had reached over 79,000 unique users. And my point with this is this is actually a throwback to the old Institute of Medicine report, The Hidden Epidemic, where they actually recommended to have a national campaign to raise STI awareness. And I would say, I don't know if that campaign actually happened post-1996, but I would like to say my recommendation would be to do something like this to raise awareness and reduce stigma, which could be done obviously with professional firm, with experience in marketing and PR, as well as CDC, plus the American Sexual Health Association. And I think making it sex positive and fun and normalizing sex and STIs. The last IOM report actually mentioned really focusing on condom use, and I have no problem with condom use, but I think normalizing the fact that everyone gets STIs, particularly HPV, and the underlying message being more, we are all going to get something someday, and then hopefully employing influencers to encourage testing. This is an example over here on the left of something that's going on in the UK right now called Long Time No Syphilis. They have very cute t-shirts and bags and et cetera. And then the other piece is to increase visibility of STIs in the lay press, and that I think can be either through experts engaging with health journalists or writing their own pieces. This is something I'm actively working on right now. I've written a book for the lay public called Strange Bedfellows, which will be published if my publisher gets their act together in the summer of 2020. And my goal with this is really getting the public as interested about this topic as they are in sex. And I know it's a big ask, but what I do in this particular book is use storytelling, humor, and science and weave it all together, because I do think these infections are fascinating, and it helps to counteract the sort of ick factor that we have in talking about STIs. So those are my wishes and recommendations in that arena. The next area where I feel like we have a big opportunity in this field is with public engagement. And I don't know if most of you know, but Alan Alda, who is an actor, writer, and director, has an encore career where he just works with scientists and teaches them how to communicate better with the public. And in his words, he said, science and the public have separated so much that people in the public consider science just another opinion. And this is actually going to become important in my next slide. Because in the absence of being able to interact with STI experts, whether it's because access to services is so difficult, or just the fact that people just are too ashamed or too embarrassed to go in, people will engage with each other for STI advice. And so this, I don't know if you guys saw, if the committee saw this in JAMA and in last month, but this is Alicia Nobles looked at the increase in requests for diagnosis of STDs on the social media platform Reddit, which has it's a sort of a social discussion site. It's the 6th most common website in the United States. It has over 330 million users. So, and you can see that this was picked up by the lay press. And then over here on the right is the figure from their paper, which just demonstrates the steady increase. And then actually at the beginning of 2019, a huge spike in requests for medical advice or just requests for answers to STI-related questions on this particular site. And then, of course, you can imagine there's a lot of misinformation being thrown around, and people actually questioning, for example, they've received an HIV diagnosis, not believing it, and asking other Redditors on the forum to actually contradict what they've actually been told by their private provider. So I know that Dr. Rietmeyer and Dr. Hook and I all sort of interacted with the press who were interested in this when this article came out. And the reason I presented this is because it also presents an opportunity for us in the field, and just wanted to say one thing that, that myself and my colleague Christine Johnston and I did We were part of a public engagement fellowship that was put on by the American Association for the Advancement of Science. And we went onto Reddit to the science subforum, which I don't know if you can see, has 22.9 million members, and 10,000 people were online at that time. And we did something called Ask Me Anything, which is a Reddit platform where experts can come and people can ask them any type of questions about anything. So we gave our credentials and gave us some statistics from the CDC, and we did an hour of question and answer, and we got 300 questions in an hour. And we just had to cut it off because we were just completely overwhelmed. But what we were able to do is link people to reputable sources of information and answer questions. And I think that this, perhaps done by health educators, not necessarily with physician experts having to do it, is a way as well to engage with the public and give them actually good information. So one of my wishes and recommendations, and actually some of the work that's being done by other organizations, would be actually to expand scopes of work for current CDC grantees, either health departments or the National Network of Prevention Training Centers, to encourage these public engagement activities. They're not forbidden at this point, but I don't know that they're necessarily encouraged. I do want to point out that it's not as if these forums don't exist. The American Sexual Health Association, or ASHA, has an Ask the Experts, where you can engage with an expert and ask your questions back and forth. It does cost $25, which can be prohibitive. So I would love to see increased funding for existing platforms such as this to be able to provide lower cost or free STI advice. And then I wanted to highlight pleaseprepme.org, where you can go online to find a PrEP provider, and as soon as you start to try to do that, a live chat appears with a health educator that says, what questions do you have about PrEP? How can I help you? And so I've visited that site multiple times, and it recognized my URL, so it said, oh, I see that you're back. Did you get your questions answered about PrEP, and what other questions do you have? So I think having that capability and that ability to engage with folks that are interested in STIs or worried about them would certainly help move the needle a little bit. So counting people and tracking our performance. It's actually not that easy. The Hidden Epidemic Report said that STD-related performance measures should be included in HEDIS and other health service performance measures to improve quality assurance monitoring of STDs. So here's the issue, which I think many of you are familiar with. Lots of health plans don't routinely collect data on gender of sex partners or sexual orientation. And so they may not collect gender also just for gender alone in a two-step process to identify current identity versus sex assigned at birth. And so we know by looking at the numerator data that we get in case reports, there's disparities in disease, but we don't even know the denominators for sexual and gender minorities to track how well we're doing with testing and treatment. So just being able to count people is a simple thing, but it's just, we can't really do it reliably. So my wish here is to collect gender and gender of sex partners, and to expand current HEDIS measures, which do include chlamydia screening in women, but to include screening for men who have sex with men and other sexual and gender minorities. And this will allow us to track trends in screening, particularly at rectal sites, for example, because those are the folks at risk of becoming HIV positive. And then we can track it alongside with linkage to PrEP, which would dovetail nicely with ending the epidemic activities. Okay, so now I'm going to move on to public partnerships with HMOs to improve STI screening. This was actually something that was called out in the last IOM report, and just a little success story here. First, data from the Medical Monitoring Project. They found that that only 36% of HIV-positive adults had been screened for GC, chlamydia, and syphilis. That was an improvement, but for MSM it was quite a bit better. 69% of them had been screened for syphilis, but only 43% had been screened for gonorrhea and chlamydia. And they were not able to look at pharyngeal and rectal screening. This was just any screening at all. So we decided to embark on a quality improvement project with Kaiser Permanente in Northern California, who serve about 4.3 million patients, and that's 40% of Northern California's insured population. And their HIV committee actually has a registry of all HIV-positive patients and tracks lots of metrics. And gender of sex partner is routinely collected at this initial intake visit to HIV care. and then included in their analyses so they can look at disparities. Now, this is not collected routinely on all members, but once you become HIV positive, that information is known. So in my wearing my hat at the Prevention Training Center, we approached them for partnership and found out they had not routinely looked at their STD screening data in HIV care and were really surprised at how low their rates are. So we decided to do a project involving self-collected rectal and pharyngeal STI testing. I just put all the papers down here to show you there are many studies saying that they're highly acceptable, that patients like them, that they can do a good job. They're just as sensitive as clinician-collected samples, and they might actually save providers time and possibly save providers' office visits. So I'm not going to march through this whole thing other than to say that we presented their baseline data to them in the September of 2012. They were all very surprised. Several sites actually began giving individual feedback to their clinicians about how they were doing with STI screening. Their laboratory validated self-collected swabs in January of 2014. And then Ebola came, and we were bumped off their lab manager's agenda 3 times until December of 2014. We met with all lab managers from 17 medical centers, and they all agreed to allow self-collection and that to happen in the laboratory. So a patient would not actually need to see a provider. They could come straight into the laboratory, collect their specimens, and get their blood drawn. And then by June of 2015, 5 labs were implementing it, and then by a year later, 17 lab sites all had it in place. So we did see we did see increases in screening, statistically significant increases in screening at any site, along with rectal and pharyngeal screening, as well as for screening in syphilis. And I'm about to get data from 2018, which we're preparing for publication. So the lessons learned here are that private sector organizations are certainly interested in partnering, but we need to lead and shepherd the efforts because they have so many other competing priorities. We have to tell them that it's important and make the case. And efforts need to be funded for multiple years because change occurs very slowly. This took, 4 years, almost 4 years to get this all done. And routinizing sexual history taking helped determine screening targets. One of the clinics that really took this on found out that really only 70% of their patients were sexually active in the last year and had indications for screening. And self-collection should be promoted to facilitate screening, both in office or in the lab or at home. So where do we go for care? So just quoting from the last report, dedicated public health STD clinics are located in every state, every major city, and the majority of smaller cities and counties throughout the United States. And I would say that's probably not the case today. I think services have certainly been stripped down. This is from the CDC in 2017, based on a 2013 to 2014 survey, that 62% of local health departments had budget cuts and had reduced clinic hours. And so just a couple of stories from my personal experience about how lack of these brick and mortar spaces affects STI care. Patients who are symptomatic will travel a very long distance to access services. So I've had 2 patients in the recent past, just in the past 5 or 6 months, one who drove from 3 hours from the Central Valley of California because he didn't feel comfortable going to a traditional primary care clinic to get STI testing because he was having sex with men. Another patient who was trying to get services in Nevada literally could not find anywhere that he could afford, and it was cheaper for the gas to drive back to San Francisco to our clinic. One clinic in Southern California, which is publicly funded, tells patients routinely it's going to be a 3 to 4 hour wait for you to receive your services. And in Las Vegas, the county's largest PrEP provider is actually this community health center. They said that routinely appointments at their clinic run out by 8 or 8:30 because it's first come, first serve. So they fill the gap, but they charge patients $125 for the initial intake. And so many people just simply can't afford it, which is why this patient, Ryan, drove back from Vegas to San Francisco to get his care. So I would love to see more access to STI screening online. This is Charlotte Gatos's I Want the Kit project, but it's only available in certain jurisdictions. There's also online ordering services, but they cost $198. So again, it's very cost prohibitive. And I would like to see, not a huge panel of tests and tests that are likely to give, false positive results in low prevalence populations, but a thoughtful sort of and thoughtful sort of menu of what is most impactful and what we should test for. So I would love more brick-and-mortar STI clinics to free up hours for existing clinics, including express visits, health departments actually performing assessments on these clinics to assure high-quality services are being delivered using the CDC quality clinical services recommendations, which are forthcoming. And then increased funding, of course, for CBOs or health departments or managed care organizations to take this on to offer free or low-cost STI testing for asymptomatic patients online. And this is something I wasn't able to put it in this talk, but that Kaiser is actually embarking on, and we're going to be doing some technical assistance with them in the next year. I'm almost out of time, so should I skip? This is my last 2 slides, but okay, so the last thing is removing barriers to expedited partner therapy. This is the map of all the states for which it's actually legally allowable. I'm not going to point out there are many randomized controlled trials to show that it works, not so much for trichomonas, but for chlamydia and gonorrhea. And several examples of how this has been done. In Washington, a community-level randomized trial where the state purchased medication and distributed it to retail pharmacies and clinics, showed a reduction in chlamydia positivity, and that was not significant because of small samples, but they did show a significant increase in the patients that got medication. And then we have a program in California which distributed about 21,000 doses of free medication for clinics. However, there's been lots of setbacks and shortcomings. The Washington program had to be put on hold for non-public health entities because HRSA is auditing them. And the California program did give out 21,000 doses, but there's over 230,000 cases of chlamydia in the state of California. So it's really just a drop in the bucket. And then dovetailing on the presentation by our HRSA colleague, under the Federal Torts and Claims Acts, insurance for the FQHCs does not cover partner treatment if the partner is not a client of the FQHC. So I would love someone to work with the DOJ to allow expedited partner therapy to be covered. And I would also love to see universal purchase of EPT meds by states to allow free partner therapy administered in retail pharmacies or distribution of prepackaged medication, and coverage of partner therapy by Medicaid and private insurers. I know it's a lot to ask, but California is trying it right now with Medicaid. Thank you. I'm sorry I went over, Dan, but I appreciate your attention. Thank you so much.